Dear esteemed members, today Chairperson Dr. Preeti, speakers Dr. Prakash, Dr. Pravithra, Moderator Dr. Vijayaraghavan, Scientific Committee members of Tamil Nadu IPS and postgraduates. Very good evening to all of you. I invite Dr. Vijayaraghavan from SCAR to take over this session.
Thanks, Dr. Pannisalvan, for such a warm welcome for everyone. Good evening, everyone, and welcome for the. I would first ask Dr. Preeti, who is a consultant psychiatrist from Madurai and who is having a center for child guidance center and has much expertise in working with young people, to give a welcome address and introduce the topic. Thank you.
Thank you, Dr. Vijayaraghavan. Good evening, everybody. It's really a pleasure and honor to chair this session on youth mental health. I thank our President, Dr. Pannisalvan sir, and the cabinet members for giving me this opportunity. As the title Enrich suggests, we are all enriching our knowledge in diverse topics. Today's topic is another area which is not much talked about in academic forum. So, youth and mental health. 50% of Indian population are less than 25 years of age, and specifically whom we call as youth, that is 15 to 24 years of age, they are 20% of the Indian population. Adolescent is the age group of 10 to 90 and youth is 15 to 24 years. So when I browsed, I could find that the World Population Prospects 2015 revision database, which says that India has the largest youth population when compared to all other countries. So, and most of the mental illness start in the early adolescent period. So that is the importance of concentrating on the youth mental health, mainly the depression, substance use, and the social behavior. Intervention needs to be targeted at the community level and the school level. I looked at the intervention studies targeting youth, but I could find only limited studies. Around 24 studies have been done. Among that, 6 are intervention studies and 3 are non-intervention studies. So there is an urgent need to address this topic. The existing youth mental health services are more illness-oriented and conform to hospitals and clinics with little room for positive mental health in youth. So a holistic model is needed to create a more resilient youth in India. In this regard, SCARF has come up with the youth mental health program, which is sustainable, reproducible, evidence-based, comprehensible, and there is active involvement of the youth. So it incorporates all levels of intervention from primordial prevention to tertiary prevention. In this regard, 2 speakers are there with us today. I invite the first speaker, Dr. Srinivasan, to talk about an integrated system of care building youth mental health in India. He is the head of Clinical Services and Training, Department of Youth Mental Health at SCARF. We welcome you, sir, to enlighten us on this topic. Thank you.
It's a pleasure to introduce Dr. Prakash. Prakash has his MD from AIMS Delhi in psychiatry and did his AB in child and adolescent psychiatry from Johns Hopkins in USA, and he has been actively involved in working with young people for the past 6 to 8 years and far further ahead also. And he heads the clinical and training wing of the Department of Youth Mental Health at Schizophrenia Research Foundation. And I think there are many accolades. He specifically works with transgenders and does a lot of work with them. And he has a lot of research articles and programs under his belt.
Thank you, Vijay.
Thank you.
That's helpful. First of all, thank you everyone for having us over to talk about this important topic. This is a topic that's really close to my heart because this is something that we want to work through and make sure that we build a better society for young people going forward. So I'm going to start off by sharing my slides, and I just want to clarify a few things. When we talk about youth, there are different definitions, right? It ranges from 10 to 25 Some people go from 10 to 35. We talk about 15 to 24, which ma'am had mentioned, right? So there are different definitions, but when we talk about youth mental health at SCARF, and I'm sure Dr. Pravithra will be talking after me, we are talking about individuals between the ages of 12 to 24, and that's who we are working with predominantly. But in order to understand why we started working with young people, we wanted to understand as to what is the current system of care here in India. Now, I have posed this question of, is this a true dichotomy, right? We talk about mental illnesses and mental wellness as two ends, as if they cannot meet. But in reality, we have to understand that mental illness and mental wellness are not diametrically opposite to each other, but they might actually be along orthogonal to each other. For example, it is possible for somebody to have mental health problems, but still be able to function and experience mental wellness, right? So it's important to recognize that, especially amongst the youth, our biggest concern is that of flourishing, wherein people have good mental health and good absence of mental illness, symptoms of mental illness, versus languishing, wherein we expect a lot more of in the absence of mental health symptoms, they still are not able to experience good mental health. And once we are able to identify that this is not a dichotomy, these are orthogonal to each other, these can overlap significantly, we come to the question of what should we do about it. So I know that these topics, these statistics were already shared. We have 365 million Indians between the ages of 10 to 24. 50% of all mental health problems emerge before the age of 18, 6.5% of community, and 23% of school samples have mental health issues. The National Mental Health Survey placed the National Mental Health Survey placed the prevalence of psychiatric illnesses for 13 to 17-year-olds in the range of 7%. So, if we were to consider even a 10% number, we are talking about 36.5 million young people who are probably suffering from mental health issues. And this is something which is huge, which needs to be addressed. And we should probably think about how we are going to go about doing that. So again, this particular data, this particular review, basically a meta-analysis looked at the age of onset, and pretty much every single mental health problem has its onset before the peaks before the age of 20 years, right? And this is really important because it tells us that the maturing brain of the young person is extremely sensitive to negative life experiences. It is sensitive to all the experiences that it does have and may be associated with mental health problems. So we want to think about a circle of risks and protective factors. And this interesting article basically talked and tried to describe the risks and protective factors in typical domains that we think about. We think about the biopsychosocial, but over here there are other aspects in terms of whether policy and institutions, because clearly young people are not existing on their own. They are existing in academic institutions. They are just entering the workforce. And so clearly those are things which need to be looked into. Family environment. It is possible for an adult who is earning to kind of move away from their family. But for young people, it may not be true. And so clearly the experiences of the family also influence the health and well-being of the children. Now, community is something really important. This is something that clearly the COVID pandemic showed the importance of. There was a stark increase in loneliness and perceived loneliness amongst young people. There was also associated increase in use of social media, but we do not know if the social media has necessarily helped or worsened the condition of loneliness. So we want to think about it as an interrelated web of risk. We think about poverty, for example. Mental illnesses in the family may be associated with poverty. Poverty can influence academic performance. Academic performance will worsen poverty. Same holds true for malnutrition. Poverty may be associated with malnutrition, which may be associated with academic performance. And we look at family conflict, child abuse. All these things do influence academic performance as one of the key areas which gets influenced, which may cause this risk of mental health problems to continue over and over again. So we really have to think about not just a one-off, let's sit in a clinic and treat somebody, but we have to take a systems view of how we are going to address this issue. So again, this is data which is available online. Other than anxiety, depression, we think about problems which people talk about include body image, obesity, eating problems, peer pressures, relationship issues. And when we talk about relationship issues, we aren't talking only about interpersonal issues within their own age group. We are talking about relationships with their teachers. We are talking about relationship or interactions with the legal system. We are talking about interactions and relationship with their family members, right? And all these things do have an important influence. Over here, as we can see, loneliness is something which was which had significantly increased over the pandemic, and it's worse in crowded places like urban centers than in rural places. Similarly, physical fights are worse in urban places. So 1 in 2 children had experienced some sort of a physical argument as compared to rural places. So we are looking at clearly a problem which has influences from the environment, it has influences from the family structure, it has influences from the kind of community supports which are available. Now, one of the studies done at SCARF was the Warwick, India, Canada study, the WIC study. And while the prevalence of depression and anxiety were 30.8 and 21.7% amongst about 15,000 school and college students, less than 15% of these students sought help, which is clearly an issue. So we went ahead and asked them as to what do they think are the problems. So, of course, stress, academic pressures, internet usage, relationship issues, need for external validation, and low frustration tolerance are the major problems that they perceived, which influences their mental health. And the barriers included stigma, and here is where the role of the family comes in. Young people have to access support from their family, and so when there is parental denial, there is really no way to access any sort of support. There is lack of resources. So trained mental health professionals who are willing to work with young people, that's a big one. Financial concerns. They do not make any money. It's hard for them to support themselves. There is a lack of human resources. There are no referral channels and no education about mental health. So they also came up with a few solutions, and those are described over here. And I'd like to highlight over here the move from the psychiatric centric to people centric. This was referred to at the very beginning, that we need to move away from a completely illness focused model to a wellness focused model. They are looking for quick and valid referrals and any sort of financial support that can be provided. So I would like, this was another study done by SCARF in association with Cities Rise. I'd like to highlight the slide section on the left, which shows the first source of support. As you can see, mental health professional is the lowest. Not even a single person highlighted the need or identified that they would seek help from a mental health professional first. Peers and friends are the go-to individual, close family is the next go-to group of people that they access help from. And so clearly, if we need to work in a youth mental health space, it might make sense to enhance mental health professional capacity. It might also make sense to do everything below, for example, school counselors, faith groups, schools and colleges, teachers, social media, even health workers. But nothing compares to when we are working with peers and friends and close family. So clearly, if we are thinking about a youth mental health program in India, we need to start thinking about where all can we build capacity. So looking at the consequences of this is the fact that in childhood, there are a lot of supports and services. Children are pretty much picked up from their house, dropped off at their schools, made to study, get their life together. But somehow magically, when they hit the age of 17, 18, they are expected to do everything by themselves, right? So as you can notice, the number of supports and services keeps reducing, but there is a huge gap in between. Independence and demands tend to increase, and this huge drop off leads to a gap which causes this particular age group, this 12 to 24-year age group, to have less supports, more demands, and not knowing what to do about it. So we need to take a comprehensive view of this. So clearly just saying that we are going to treat all individuals is not sufficient. We have to think about universal prevention. We have to think about selective and indicated prevention. Indicated preventions are directed towards people who are at extremely high risk of developing mental health issues. They may have preliminary symptoms, but they are just not meeting criteria for a caseness. So we have to think about how are we going to prevent the development of mental health issues. We have to think about early identification, early treatment, and also long-term care, because some of these illnesses have a lot of recidivism and we need to address that. So what does this mean for youth mental health services? They have to be comprehensive. What do I mean by that? They have to talk about the needs. So they have to address wellness. They have to talk about illness. They have to talk about prevention. They have to talk about providing the necessary support so that there is rapid integration and rehabilitation of individuals with mental health problems. It cannot be either or. It has to be inclusive. And this is something that we talked about just now. Inclusiveness includes the parents, the teachers, the peer group, the administrators, the policy makers. It includes anybody who is touching this life of this particular young person. Youth mental health services have to also be participatory, and this is something that is just coming up. So involving young people in making decisions about how and what issues need to be addressed provides them with the necessary tools so that they are able to support themselves in the future. It has to be accessible. Clearly, a run-of-the-mill running a clinic may not work for everyone. Young people may want access to services online, and clearly providing access to services like that would help them. We have to use innovations. Clearly, just doing the same old thing, sitting in a clinic, may not be useful. It is something that needs to be addressed over a period of time. And clearly, innovation doesn't have to come from us. As we do comprehensive, inclusive, participatory, and accessible services, automatically innovation does develop, and it is an organic process through which we are getting newer ideas which we can implement and study. So I'm going to stop with this quote about talent is not equally distributed. Talent is equally distributed, but opportunities are not. We really need to take a social determinants of health perspective when we are looking at youth mental health. And clearly, mental health problems or the mental health risk factors have an undue impact on young people's brains and their future life. So clearly, rather than thinking about opportunity as only the access to services, opportunity should also think about what all can they learn upfront so that they are able to address their mental health issues as time goes by. So I'm going to stop with that and pass it on back to you, Dr. Preeti.
Now I would request Dr. Pravithra to present a quick introduction about Dr. Pravithra. Dr. Pravithra did her MD in psychiatry and currently working as a consultant psychiatrist with Department of Youth Mental Health and Research Foundation. And she is actively involved in clinical services, research, training, and whatnot, and everything she's involved in. And she's a rising star, and she's been able to secure very many funding opportunities to work with young people. And she's also concentrating a lot on working with government schools also to provide training and support for the students there. I would request her to present her topic, which is going to be more on what SCARF is doing on youth mental health in the institution as well.
Thank you, Dr. Paneerselvan, for this wonderful opportunity. And thank you, Vijay, for that warm welcome. So at the outset, I must say that it gives me immense pleasure to present the collective experience of SCARF on behalf of the whole team of YMH. And I think I also need to give a disclaimer that this presentation is a brief overview and is not a comprehensive one of all the vast experience of work that has been done at SCARF over the years. And I'm really happy to be presenting a part of it. So when I speak of our experience in the youth mental health, I want to address it from three broad verticals. The first of which is clinical services. The next is research activities. And the last is outreach and training or capacity building. And in each of these areas, one important component, like Dr. Prakash had mentioned, one important component that we try to stay true to and thrive in is a participatory approach. So when I say participatory, it includes participation of the end user, here the young person, in each and every area of all these three verticals, be it in clinical services, be it in the research that we do, or in the outreach, what we do, where we give it, is all designed, evaluated or inquired by young people. And there is an element of them delivering it as well as dissemination. So young people or the end users are involved in all the activities, and the whole process is built based on what their needs are and trying to stay relevant to their needs and expectations. And across this presentation, I've tried to explain on how we thrive in this framework in each of the verticals. So starting with the clinical services. So the youth mental health program activities at SCARF began in 2003 with the initiation of the first episode psychosis services, and the clinical services as such was delineated in 2017, and as a department we've been functioning from 2022. We cater to the young people in the age group of 12 to 24 years. We provide both outpatient services and inpatient services for people above 18 years. And we adopt a multidisciplinary approach. We have a young team of psychiatrists, psychologists, and social workers who provide a more holistic approach in the services that are provided. And the FEP services, we will just be talking about it shortly. And there are also peer support activities that we include in the clinical services. So the participatory approach to this is the element of co-design. So we recently had interviews with patients, caregivers, the clinicians, service providers, and the management in understanding what the needs of young people are when it comes to services that are being provided. How would they like the services to be provided to them, which could include what timings it can be, how the place should look, how the clinicians should work, how the management should function. All these questions were asked to them, and their qualitative responses were understood. And we tried to develop not only questions, but also come up and co-design suitable solutions for handling each of the requirements. And these requirements were then grouped into short-term goals, intermediate goals, and long-term goals for change and for building. So basically, when we are looking at revamping and remodifying the youth mental health services that are provided, we try to do it along with an evidence-based approach of what young people as such require. And one particular modification that we've made, or inclusion that we've made, is to have an evening clinic, because that was something that was asked. Usually our clinic functions between 10 to 1, which is working hours for young people as well. So something that came up was to introduce an evening clinic, and that is something we've been floating since April of this year. And when it comes to FEP services as well, it was one of a kind when it started off in South Asia in 2003, where we provide early critical interventions for psychosis, which includes training family members, psychoeducating them, improving compliances, adherence to medication, and in turn improving the remission as well as relapse prevention among young people who have psychosis. One of the recent activities that we've been doing is to develop an advisory board. The ADEPT team came up with an advisory board, which includes people with lived experience, caregivers, service users, clinicians, general physicians, students, and youth representatives who are now being trained in what psychosis is, what their life experiences are. So they are also being trained in aspects of mental health. And so are we gaining. So there's a lot of cross-learning where we are also gaining on what their requirements are in terms of how the program needs to further be modified or developed in order to give a culturally appropriate care which is relevant for patients who are experiencing psychosis. With that, I would like to focus a little on the research activities that we've been engaging with. So when it comes to research, we focus on a large, diverse setting. This includes schools, colleges, communities, and workplace. Basically, everywhere where young people are available in this age group are areas where we focus on in terms of research as well. And like Dr. Prakash mentioned earlier, we are looking not only at mental illness, not only focusing on the clinical aspects, but also rather on a wellness perspective, on positive mental health. Across the mental health spectrum are areas where we focus on in research as well, which is done by different research methodologies, which can be qualitative, quantitative, and using a mixed method approach, where we're also getting interviews and feedbacks as well as one of our important components. And we work on all the intersectionalities that were just mentioned. We work on areas of bioethics, on implementation, on areas of public health, policy, advocacy, are all the areas that we try to focus on when it comes to research. And one particular area that we've been focusing in the recent past is working in arts, using arts, experiential learning as a method of delivery for both mental health literacy facilitation as well as for facilitation in mental health wellness in areas of positive mental health, which includes character strengths, building areas on interpersonal relationships, social connectedness. So basically areas that young people feel are relevant to them to build their overall wellness are areas that we work on in terms of facilitation, and that we're doing through arts. So here are a few of our facilitators, youth facilitators, who've been working in schools as well as in urban slum communities and in colleges through different arts-based approaches. This can include visual arts, this can include a sense of movement and use of body, and aspects around using games or theater, which are more experiential in terms of understanding what these are. And it is expected to bring about change in not just their knowledge, but also in their behavior, their attitude, and overall sense of wellness. And the areas of focus of some of the other research projects have been, one is the WIC study that Dr. Shiv had just mentioned, which had screened about 13,000 students across 9 educational institutions. And the other is working in areas of vulnerability. Working with vulnerable youth is the focus in the JAMS project, where we've been working with childcare institutions along with the Juvenile Justice Board, where across 2 states, both Tamil Nadu as well as Orissa, targeting about 350 children and staff as well as administrators. And here we've been working again on areas of mental health literacy, creation of a safe space, and also providing access to care and referrals. And we've been also working on areas of intergenerational conflicts, working on the uptake of mental health services. And one interesting area is also the development of an app-based intervention for self-monitoring, for peer support and referrals that are available for college-going students, both to understand what they're going through, as well as to reach out for support when there is a need. And that is the aim of the YES project as well. So when it comes to outreach, we hope to work on all the levels of this pyramid. So when we're looking at tertiary care, we work with mental health services, with healthcare professionals, and also with academic institution at the community level and at an individual level when it comes to understanding early identification, when it comes to understanding access to care and referrals, as well as in areas of health promotion and prevention. And during our work in this realm, one important thing that we've found is very essential for us to work at outreach level is good partnership and collaborations. So we've been able to collaborate with different schools, with the Department of School Education in the Chennai Corporation as well. And through that, we've been working in different schools to cater to the needs of the children, which could come from the Department of Education itself. Like they have invited us to give talks and to address children across different Chennai Corporation schools for when it comes to exam stress, when it comes to managing substance use. So these are areas where we've been working, and they've also been very proactive in taking up suggestions from us when it comes to working in other areas of mental health literacy, in creating awareness, in building the referral systems, and also working in general mental wellness as such. And like one of the projects that Shiv had mentioned earlier, we understand that it is not enough to work only with the young person. It is very important to work with their environment and all the elements of their environment. And that is when it comes to working, especially with teachers in schools. We've been running teacher training programs where they are also educated on these areas, and we follow them up and mentor them in them delivering these services to their school children is one aspect that we look at. And also young people always reach out to other young people in terms of need. So building peer support also becomes an integral part. So those are aspects that we've been focusing with in collaboration with Kriya University to train, to have peer support volunteers in their own university, where they will be able to address a few aspects, provide barefoot counseling, and when there is a need to also be able to refer the young person for subsequent support. While this is happening at academic institutions, it's very important we understand to also work at a community level, to work at the place where young people are there, their residences. So when I say community here, the aspects that we've been able to focus on include urban slum communities in Chennai. So we've been working with different community-based organizations who already have a social footing in these areas, and partnering with them, we've been able to deliver these services to young people, either as a part of our outreach programs or as a part of our research activities. But something that we realized is very important is sustainability. It makes it very difficult for us to deliver all these activities or deliver these programs in a continued manner. So that is where the TOT model comes into play. And we've been increasing and building the capacity of the community level workers in all our partnering community organizations, both in working on MHL as well as in arts-based facilitation. So we've been working on specific areas of theater of oppressed, where they can engage with young people in their communities on their own in a way that is more relevant and more interesting for the youth. And this is also one of our interventions that we've had with youth trainers from the community. While we've covered a few areas at the base of the pyramid, I think it's very important to also address the apex of the pyramid, the tertiary care system, and working with mental health care professionals. Here, we've been able to successfully, with the help of the TNIPS as well as our funding partners, we've been able to conduct clinic to community-based workshops. Over the past year, we've conducted 3 workshops, and even before that, even before COVID, we had conducted one such clinic to community workshops, where we work with all mental health professionals, including psychiatrists, psychologists, social workers, in building their training specific to youth mental health. We all have adequate training in our own areas of expertise, which is a lot clinical. But when it comes to working with young people as such, there is a more holistic approach that we need to take. When we are working as such in the school or in the community, there are areas of group facilitation and skills that we may additionally require, additional support that we may require. So these are areas that we've been focusing on in these C2C workshops. And we've been also training the mental health professionals in arts-based community engagement, and also trying to establish a cohort, because by the outreach activities or by the research activities, we are able to, in a very small step as such, been able to create an awareness and building a need for referrals. But it's also important to strengthen the referral system that we have. So that is also one of our primary aims in the C2C workshop, to establish a cohort of mental health professionals across the city, across the state. And across all these areas, youth engagement, as I said, has been a very important part. And some ways in which we've been trying to engage in this are through the youth advisory boards, who have been able to design these interventions for us. We only have youth trainers delivering these interventions in the community, because young people have always found them relatable and found interventions through them more fun and more acceptable. And there is always training in child protection policies that is offered to the youth advisory board members as well as the youth facilitators before they engage with young people. And one particular area that I would like to focus on is the rYMs space. This is a safe space that has been created, which is inclusive, supportive drop-in space that is run democratically by youth volunteers. This is not as such to talk about any particular mental illness or mental health awareness as such, but rather a space where young people can engage and interact with each other in a more mental health friendly manner, with interventions of their choice and sessions of their choice. And our volunteers in the past have had jamming sessions, have had sessions on arts-based activities that they could do. They've had games, open mics, and these are different ways in which they've been engaging. They've been managing these spaces, conducting these activities, also disseminating these activities, being active on social media. So it gives them entire democracy in doing what they want to do in a mental health friendly manner. So I think with this collective experience, we understand that it's very important to go forward as a group in a collaborated, partnered fashion to take care of the child, in terms of creating a safe space and a supportive environment for the youth, to help youth engage not just in understanding what illness is, but rather to work on the positive mental wellness spectrum, to identify young people and caregivers who may be in need and provide referral systems, and also to link families and the information services for both health and well-being, and to develop an organizational and community strategy for well-being. As such, I think the areas that we're trying to work on is primarily the intersectionalities of youth mental health, which includes social identities, social systems, as well as an impact. I would like to stop with this and also say that this is our Instagram page, which is also run by young people from our team. And maybe it would interest you to follow that and keep in touch with us.
Thanks, Pravithra, for the lucid presentation and sticking with the time. In the interest of time, I would rather say that if at all there are any questions, both the speakers are open for taking questions, and we can take 2 or 3 questions, I guess, max. And
I would go with my questions. Thank you, Shiva, Prakash, and Pravithra, for your lucid presentations. My question to Pravithra, was life skill approach employed in community-based interventions, or more of theater-based or art-based or stress management sessions were conducted?
Oh, thank you for the question, ma'am. As such, I think arts is only a mode of delivery. It is not the content as such. So we've been trying to work on different aspects, different content, which is being delivered through arts to make it understandable. And when it comes to life skills, we also understand that in the communities, a lot of community-based organizations are also already working in life skills. So there are components of life skills that we may be delivering, or otherwise there is also an element where we support the community organizations in the interventions that they deliver, as well as include and support them with the modules specific to mental health literacy that may be required. So it's basically what they're already doing and we supporting them with that, and using arts as only a mode of delivery for some of these activities, because that definitely we understand is very relatable and engaging for young people. And also I think it brings in the element of experience. So I think that's where arts comes in.
Thank you.
Preeti,
Sir.
Dr. Pravithra, are you conducting any clinics in SCARF, child guidance clinic, youth clinic in SCARF?
Yes, sir. We are having a clinic with outpatient services as well as inpatient services, catering to young people in the age group of 10 to 24. The IP as such for now is only for people above 18 years of age. We don't have a child IP as such, but otherwise the OP is for everybody.
You have a collaboration with the colleges, schools in doing this work?
Yes, sir. So we offer, I think Shiv will also be able to back me up on this. And we offer services in the colleges and schools, and also offer referral system. So that's also even in the communities. So if there is a need, then we are able to also engage with the young people in need when they are referred to us. We don't offer outreach clinics, if that's what you're asking us. As of now, we are not giving any outreach clinics.
Okay.
And just building up on what Pravithra mentioned, outreach requires more staffing, and clearly that is a huge issue. But on the other hand, one of the things, like Pravithra can also attest to the fact that recently our work with our community-based organization has been a great source of reference. Our work with childcare institutions has been a great source of reference. So with colleges, we have MOUs, for example, with CREA, we do teleconsultation for them. And colleges, academic institutions are in a better position to kind of fund and support mental health services for young people, so long as they don't need to employ somebody full time. And we are able to fulfill a small gap over there, so our mental illness-based services happen through SCAR, but all our other activities happen through outreach and community-based work.
Dr. Shiv Prakash, I wanted to ask you that in Western countries, any teen can approach teen clinic without a parent or guardian. Is the same applied here in SCARF also? Because when a teen comes to my clinic, automatically staff will say, go and bring your parent. But that should not be the case. So
I completely agree with you, and we have this huge discussions about the ethics of allowing a young person to seek help, especially when they are able to identify and also say that these are the problems. We have always taken individuals above the age of 18, even if they come independently, in the sense that we have never asked for a family member unless there were concerns, right? But young people less than 18, we always have a family member involved, and that is just as a policy because we don't want to make it step on any legal toes, so to say.
Thanks. Are there any more questions?
Yeah.
Please, please go
This
ahead.
is Dr. Selvaraj from Coimbatore, from Vadigati Mental Health Center. About 15 years back, I visited Singapore. And one of the places I visited out of curiosity was a youth mental health service. It was placed in a mall. And I went in. It was more like a lobby, and there were board games and cool drinks, snacks, and very colorful environment. And there was 2 psychologists, youngsters were there, and a lot of college students were hanging around and playing with each other. And there were a lot of brochures were there, and there were some questionnaires were there. And you didn't get the feel of a clinic or a health-related place. But they were reaching out, and at that time it was an experiment because it was placed in a mall. It was very, very unconventional, and that is the reason I visited that place. See, in Coimbatore, as you said rightly, the youth population is huge and the felt need is there, but they don't come to psychiatrist or even to counseling centers because of the stigma. So unless we devise acceptable delivery setting mechanisms, we cannot truly reach the needy. I mean, my 2 cents.
I feel that the app-based interventions will be more promising, and the SCARF has come with it. Does it have a name for? Is it available in Play Store?
Yes, ma'am. We will be happy to share the link. It's called DSM.
Are there any more questions? I think it's getting delayed, I guess. So,
Yes, yes, Dr. Vijay, we can wind up.
sorry, sir?
You can give a conclusion remark so that we can wind up.
Yes, please. Yeah. Thanks everyone. And first, I must thank the chairperson for chairing the whole and providing a brief overview and asking more pertinent questions. And I also thank the speakers, Dr. Shiv Prakash and Dr. Pravithra, for the very erudite presentation. And I think it would have kindled a lot of interest among the psychiatrists here. And it is, at least to my mind, youth mental health is more like a network where we have to work together, and it has nothing. It has clinical services one component, but it is actually only one component of it, and we have to actually collaborate with so many people so that we will be able to bring in a holistic change among young people. And as Dr. Silva said, I think you have to actually think of outside the box and bring in other partners where we will be able to collaborate with them. With this, I also thank TNIPS, and because one of the important things Dr. Paneerselvan has approved is that to have a subcommittee for youth mental health within this, so that it is a huge step towards making that, giving kind of a power to people that, okay, youth mental health as a separate one can be thought about, it can be discussed and can be worked on. I think that's a huge step. Nobody took that in India. I think Tamil Nadu, TNIPS is the first one to do something like that. I really appreciate on that. I hand over this to Dr. Panniselvan.
And thank you, Dr. Vijayaraghavan. A very good deliberation by Dr. Prakash and Dr. Pravithra. They explained in detail about the youth mental health and also the SCARF experience. I thank the chairperson, Dr. Preeti, and moderator, Dr. Vijayaraghavan, all the members for the active participations. Thank you all. Meet you in the next webinar.